Good morning. I'm calling to order the Board of Health meeting. Our first item of business today is approval of the minutes from March 13th, 2008. Do I have any comments on the minutes from the board? Dr. Foreman.
Thank you. I just wanted to make a comment that I thought the minutes were extraordinarily accurate. It was very hard. I found two very small corrections, which I typed up and I'll hand in. That's probably not worth mentioning. That's it. Thank you.
Thank you, as ever, Dr. Foreman. We have today 6 additional items of business. 3 are, we have to vote to approve. Second, thank you. All in favor, please say yes.
Yes.
That was unanimous. Thank you for approving the minutes. To continue, we have 3 items of business today. 2 are notices of adoption. So these have been previously presented to the board and open for public comment, followed by 3 resolutions that are proposals for publication. Our first one is the notice of adoption to amend Article 43. Do we have a presentation? Could you introduce yourself to the board? We're going to be reviewing 2 and 3 together. So this is a notice of adoption of a proposal to amend Article 43 and Article 47 related to both school-based and child care programs and family shelter-based programs.
Good morning. I'm Corinne Schiff, Deputy Commissioner for Environmental Health. Corinne Schiff, Deputy Commissioner for Environmental Health. And I'm here with Monica Pollack, who's the Acting Assistant Commissioner for the Bureau of Child Care. We're here to present the proposed notice of adoption for Article 47, which addresses child care, and Article 43, which is school-based programs. But I cannot turn the page. There we go. To refresh the board's recollection, we presented a notice of intent in March, and the provisions were to clarify certain provisions to facilitate compliance, to require toothbrushing, to require epinephrine auto-injectors, and to enhance training requirements. We published the notice for comment, including, we sent the notice, Dr. Foreman, thank you for your suggestion. We did send it to the American Academy of Allergy, Asthma, and Immunology, as you suggested. We held a public hearing, 27 people testified. We received 92 written comments. First, on the toothbrushing proposal, we received many comments. We received comments in support, in opposition, requests for changes, and the department will further consider the comments. We need more time, and so we're not asking the board to adopt this part of the proposal at this time. Turning to the proposal regarding epinephrine auto-injectors, we received comments in support that this proposal would help programs manage emergencies. Comments in opposition addressed costs, concerns about being able to recognize life-threatening allergies, and that the auto-injector is difficult to use. We received a request for clarification regarding storage, and a request to expand to other emergency medication for patient-specific nebulizers and inhalers for children with asthma, and for patient-specific epinephrine auto-injector. Responding to those comments, we've changed the proposal to specify that the auto-injector has to be one with a retractable needle, and that storage should be in accordance with the manufacturer's directions. We think that our guidance and the mandatory training will address concerns about administration of the medication. The mandatory training does address the signs and symptoms of allergies, life-threatening allergies, and there's really a very low risk of inappropriate administration of the epinephrine. And I'm pleased to say that the department has secured a 1-year donation of auto-injectors for all of the programs that would be covered by this should the board adopt it. Regarding the request to expand the proposal to other emergency medication, just to set the context, currently the Article 47 requires that programs have a medical administration training certification in order to administer medication. The certification is time-consuming and expensive, and only about 10% of our programs had it. So this amendment would allow administration without the MAT certification for patient-specific asthma nebulizer or inhaler or an epinephrine auto-injector. And this would be only for a child with a prescription and an individualized medical plan with the consent of the parent and training by the parent of the child care provider. Turning to the requirements for training enhancements, we received support for extending these trainings to all teachers, and comments in opposition raised costs, that this was time-consuming, and asked for more time. We continue to think that these training mandates promote the goals of high-quality childcare. The changes that we're proposing to the board are that we specify that at least 5 hours of the training toward the required overall 15 hours every 24 months be done in the first year, and that we add the infection control training, which we had specified in Article 47, to Article 43. And I'd be happy to take questions.
Thank you. The presentation is now open for comments and questions. Any comments or questions? No? Dr. Foreman.
So thank you. I was all prepared to talk about toothbrushing, but I guess next time. There was one new item you raised, which is this idea that for patient-specific exempt medications, that the parent would teach the staff member. Is there any provision for staff? Are staff members obliged to do that, or if they are uncomfortable, do they have a way to opt out? Is there an obligation, in other words?
We are not including a mandate here. I will note there may be ADA requirements, but in terms of what we would put in the health code, we would not be mandating that. We'd be creating an option for parents and programs.
That's great. I think that many parents will appreciate that greatly, that this is allowed, that they can, as was mentioned in the last discussion in the last board meeting, the use of auto-injectors is really very simple. There was a mention in one of the comments about a 45-minute training, which it takes about a minute to teach someone how to use one. So this seems great. Thank you.
Just in response to that, thank you very much for this summary and update. I think it's important for the department to really incorporate the comments that come out. It was obviously a big issue for so many providers. But just in response to that, I don't think it's a question of necessarily the administration of the auto-injector, but it's maybe discomfort with understanding when it needs to be administered. I think that's much more complicated for non-health providers to be comfortable with, and I think that came out a little bit too. So I think the training does need to be sufficient so somebody feels comfortable making the decision to actually implement it. So in reading the comments, I just wanted to ask a few questions. Some of the daycare providers were concerned about liability. How do you, identify, how do you obtain the auto-injectors, which I now guess are going to be donated this first year, but the cost of that and, how they expire and, is there increased liability for the daycare provider if God forbid, something, were to happen when it was inappropriately administered or not for the right reason or whatever. I just wondering if you could speak to that.
Well, with regard to liability of using the epinephrine auto-injector, you'll remember that this proposal incorporates a relatively new state law, and that state law does have a Good Samaritan liability provision, so it would treat the use of the non-patient specific auto-injector in the same way that it treats first aid administration and that sort of thing. Whether a particular program will see increases in their insurance costs, we did do a little bit of research into that, but everyone's program is is different. Everyone's program and policies are different, and so we didn't feel like we could really address that in detail. But we do think that it's, and as I think the board discussed last time, that this is an important program to help the providers be able to address very, very serious emergencies and be prepared to handle those.
Right. I'm just wondering what has been the experience in the past with children needing auto-injectors for this age group. I'm wondering how many have experienced that.
We tried to look into that. We don't think that we would necessarily know when there was an incident, and if the provider calls 911, they need to report that to us. But if they call a parent who comes to pick up a child, we wouldn't necessarily know. So it was hard for us to get a sense. I think we reported last time the percentage of children estimated to have life-threatening food allergies, but how often the programs see this, we really weren't able to set a number.
Okay, thank you.
Dr. Foreman.
Can I just follow up to clarify one thing about the new, I wonder if you could bring up that slide that had the exemption. That one. So the amendment, the exemption here is for patient-specific epinephrine auto-injectors in addition to nebulizers. We were talking about non-patient specific. So I'm trying to clarify the training requirement, as Ms. Redlener pointed out. Is it different? So this exemption, these people would be trained by the parent. There's no requirement for formal training. But for the patient not specific or not patient specific one, there is a requirement for formal training. Is that correct?
Right. So this microphone is not going on, so I will. Oh, thank you.
Yeah, thank you. Right, so there are two different pieces to this. For the non-patient specific auto-injector, it is up to the program to identify staff to be trained so that they could use this in accordance with state law. State law requires a person to be trained in order to use a non-patient specific auto-injector. And so the program would identify, we assume, more than one because they need to have somebody on staff all the time. That would be one kind of exception to the MAT certification requirement now. We're suggesting to add a second exception for a child with a prescription and a parent who wants that provider to be able to administer that child's auto-injector to that child. And the parent would conduct that training. And I'll just note that we are mirroring a state regulations, and the state has done a similar thing for its home-based child care providers.
Thank you.
Dr. Richardson.
And there's no specific time requirement on the non-patient specific auto-injector training? I'm reading through the language and it simply specifies what needs to be covered. Okay.
So should the board adopt the proposal, we will be rolling this out over the next few months and setting a time we will, through guidance, set a time for the programs to do training, and in order to receive the donated auto-injector, they would demonstrate to us that they have been trained. And so it'll be over the course of the next few months that we get the programs trained, and then we provide this to them.
Dr. Gowda.
Dr. Gowda, I want to thank you for this presentation. So one of the main concerns of the persons who submitted comments was about cost. And perhaps you already mentioned this in your report, but I was wondering if your office estimated the cost of maintaining the supplies of the epi-injectors and also the staff time that would be required for training or costs of training. I know that the first year would be donated, but beyond that year.
So the auto-injectors range in price. Roughly about $500 would be a typical price based on our research. The training, you can take, the requirement under state laws to take a nationally recognized training. We anticipate that with this requirement, there may be new trainers that appear. One training that we have identified that would qualify under state law costs $25. It's up to the program, the size of the program, how many people they're going to train to maintain the requirement that there always be a trained person available when children are there. So it's really, it's hard for us to pinpoint exactly the price. We are pleased with this donation, and we're certainly looking into how we can continue to support the programs.
Thank you, that's helpful.
And Ms. Redland.
Thank you for that information. I just want to ask a question about one of the other topics that we didn't get a lot of detail about, but it's something like enhanced regulations on facilities and fines. Is that something that is part of this amendment as well?
There were quite a few comments concerned about inspections and fines. That's not in this proposal. That's about the inspection process.
Okay, so that's not part of this, even though, okay. And other trainings that we're now mandating as a result of this is more than just the medical administration training for the auto injectors, right? So there's a number of additional trainings and certifications that we're requiring.
Correct, and I did not include that in the presentation because we really didn't get comments about the specific trainings. And so we just made these two relatively small additions, and that's why I didn't include them here, but I have it with me if I can go back and review what those trainings were.
Well, actually, I'm interested, it just seemed there were this sort of feeling or communication from the comments that the communication between the Department of Health and the providers was maybe not as enhanced or supportive as it could have been, and people are not necessarily aware about implementation schedules and resources when things are changing. So I'm just wondering if you could speak to sort of the implementation plan and the communication plan to providers about what the new regulations are.
Sure, we did note that, and we take that seriously. I can share with the board that we have recently enhanced the way we train providers. We did a series, for example, a series of web trainings in the fall about some new programming, and invited all of the child care programs to sign up by an email function and to do a webinar that was very well attended. And so that's a model that we're going to continue to use. It's a low burden for the programs. They don't have to come someplace. They all seem to have internet access, so we think that that's a good model. We will be, as we do every time we change the code, we'll be developing guidance materials, we'll be sending those out, and we'll be setting up trainings as well. But I understand, we noted that as well, and we're working to do as best we can.
Great, and there's a 3-month notice or a 6-month notice or some process for notifying people, and they have some time to get up to speed with what the new requirements are.
So certain of the provisions had express implementation dates, and where it didn't, we will be rolling this out as a matter of our discretion as the enforcement agency to provide time and guidance for the centers to comply.
Great, thank you.
Dr. Carroll.
I would like to learn any data from the past on the use of EpiPen at the school level, number one. Number two, I'm worried about the teacher's burden. As far as I know, the public school, they have a health care nurse or health care medical assistant qualified with license at the level of the public school, but many private schools will have to recruit teachers who, on a volunteer basis or whatever, will come up in front to do the job. And I'm worried about the burden because they have to report how to use it, how, in what moment, the symptoms, etc. I just want to express my concern about that.
We don't have the data on the number of uses. We don't think it's very high, but we don't have those numbers. And it's for the board, I guess, to weigh the burden on staff. It's our view that the burden is minimal and relative to the benefits of having the epinephrine auto-injector and trained staff on site for children who might face life-threatening allergic reactions.
Thank you for the presentation. I think it's actually a very important enhancement to the quality standards for childcare in schools and in other settings. And I also just want to note that we have defibrillators in restaurants. We have no peanut notices on airplanes. that life-threatening allergies are very serious and very prevalent now, and it seems a low-cost, low-demand way of keeping the kids alive and safe and making sure that the staff can focus on the things that they're there to do, which is healthy child development and early education. So I just want to say thank you for that.
Thank you, Ms. Nawas. I think that sounds like a nice summary comment. Do I have another hand up? Dr. Raju.
Thank you, Commissioner. One of the suggestions maybe you need to explore is there's a 340B program which discounts enormously the cost of this particular $500. I think probably you can explore that possibility because you do get those things at a discounted price, like the public hospitals and federally qualified health centers do get that much more cheaper. So just to take if you don't mind looking into that.
Thank you for that suggestion.
So we are now up to taking a vote on these. If there are no further comments, we'll take two separate votes. The first one on item number 2, the notice of adoption to amend Article 43 on school-based programs for children aged 3 to 5. May I have a motion to adopt?
Second.
All in favor, please say yes. Any one abstention, and from Dr. Caro, the rest in favor. Thank you. The motion to adopt passes. We have one additional vote to take. This is the notice to amend Article 47, which refers to child care programs and family-based drop-off child supervision programs. May I have a motion to adopt Article 47? And a second. All in favor, please say yes. Aye. All right, that was unanimous. Thank you very much. The motion carries. Our next item of business is notice of adoption to amend Article 207 of the General Vital Statistics provisions. Our registrar will present. Please introduce yourself for the record.
Good morning, my name is Stephen Schwartz, the New York City Registrar. The department is proposing to expand access to birth and death records. So we received a lot of public comments. The issues that were raised broadly are that birth and death records are protected from access to the general public because they contain individually identifiable information, which is considered private. We also understand that they are also historical documents of interest to family members and persons researching their ancestries. So we've learned a lot through this process, and we are looking to balance the concerns of privacy and also increasing access to the extent that we feel is reasonable. So we do believe that certain family members should have access to birth and death records prior to the records becoming public. The board members will remember that we had proposed recently that, and it was approved, that birth records be kept private for 125 years and death records for 75 years. So given that, we are seeking to have the relaxation, if you will, of access to records. The privacy of the vital records will still be protected for those appropriate periods of time. It's always nice to get mail. We received a lot. We received almost 1,000 comments, mostly from a petition, and we also received some compliments that we were actually heading in the right direction, that we many of the commenters were very pleased at the proposal to expand access. They would perhaps like a little more than we would. We are still proposing to exclude important family relationships such as adoptees, step-family members, and other family generations. One of the problems with responding to access to, say, step-family members is we have no proof of relationship. So that makes it difficult, and there are always dividing lines. We feel we have drawn them fairly. Also, non-family members cannot do research. It was strongly suggested from the researchers that we should create a category for researchers like genealogists. We talked about the 125 and 75 years. Another request was that we create unofficial copies of birth and death records for genealogical purposes only. We think that's a really bad idea. If the records should be open, they should be open, and if they're closed, they should be closed. But simply stamping something not for legal purposes is a problem. So another point that we listen to and are paying attention to is that we had complaints, valid ones, that we were not following our own existing rules consistently. So we have plans to do much better about that. So we certainly agree that clarifying rules and procedures and improving our website are really important. The website today, probably most people use Google rather than trying to go through the health department's website. It's unfortunate. We have to do better there because we serve a huge population. We issue almost, some people think I sign all of them. We issue almost 1 million certified copies a year. Even more than I can handle, even when I take work home. So we have to do a better job of that. So we feel that the new rules will provide substantially greater access to family information, and we're also proposing that the new rules not take effect just after 30 days, but give us until the end of the year so that we can train our staff and provide better information on our website and be more responsive to our constituents. So the expanded access provisions include, we want, if somebody wanted a birth certificate of someone who had just died, we want proof of the death. Shouldn't be a hard thing. Proof of relationship, that's a bit tricky. We are going to change our forms, we're proposing to change our forms, which is within our control, to require an attestation or a notarized request, so that's the way we'll enforce it instead of trying to have somebody come in and prove that they are your sister or brother. We did an informal poll around our office, and it was really hard to do. So we're sensitive to that, and we feel we are addressing these concerns. Also, the expanded group will be able to get birth and death certificates before they are public. And also, certificates of birth and death will include parents' names and birthplaces. That's really important for people who need, for example, access for dual citizenship. So our our full certification, certificate of birth, has parents' birthplaces. Very important for dual citizenship purposes. We will be making it easier to our customers to have access to those records. So with proof of death, these relations will now have access to birth certificates. The spouse, domestic partner, parent of a child over 18, child, sibling, niece, nephew, aunt, uncle, grandchild, great-grandchild, grandniece, and grandnephew. We did this basically based on talking to our own staff and some complaints we get, and realizing that we have to have this expanded group because they need the records. And also now these relations will have access to death certificates. Great-grandchild, great-great-grandchild, nephew, niece, aunt, uncle, grand-nephew, and grand-niece. And we already have, so you can see the expanded access there. And with that, I will answer questions.
Thank you. Do we have questions for Dr. Schwartz? Dr. Klitzman?
Thank you, Dr. Schwartz, for updating us and for the department's thoughtful attempt to balance all the concerns that were addressed. Just a quick question. Do the relations include relations by marriage, such as a aunt or uncle by marriage, or only blood relatives?
Relationships work. Yes.
Thank you.
I don't understand the
I
answer.
think the
Oh, I'm
answer
sorry.
is yes.
A spouse can get it.
Yes, that was the question, relationships by marriage. So an aunt or an uncle by marriage would be included in this group, is that correct?
Yes.
Thank you.
I also want to extend my appreciation for the openness, the expansion of access, because I think it's important for many reasons. I'm just wondering, how do people prove their relationship? Grandchild, great-grandchild, what is required to prove that relationship? Just attestation, or?
We are a trusting agency. Well, I say that only half facetiously. We have found that it is just almost impossibly difficult to satisfy people's needs without having the use of an attestation. So I gave the example of how do you prove that you're a sister? Well, it actually can be quite difficult, and it can be costly, it can be really time-consuming, it can be really complex. So we feel that an attestation will be serious about that, and so it will have to be notarized. We're going to change our forms, and we're also going to have those forms in all the appropriate languages for New York City, so that people will understand when we say you are attesting to this, that they will understand it in their language.
Thank you. And is there a cost to people for, obtaining a birth certificate or a death certificate or multiple or whatever the request is?
Yes, the cost is $15. I like to say 3 for 45.
That's a deal. Okay. And, just wondering about the time frame, or somebody sends in a request or brings the appropriate paperwork to the office or whatever, just curious about how long. I know last meeting we said maybe they walk out that same day with something, but typically, what is the time frame for people getting access to the documents?
I'm very glad you asked, because we move almost lightning fast. So we have about 600 walk-in customers a day. They walk in and walk out with that certificate. We have electronic kiosks. We have an electronic challenge response to identify who they are through a product called ProCheck Pro ID. So they walk out with a certified copy. Also, they can be, through the wonders of modern electronics, we can either issue a short form birth certificate or a long form birth certificate now while they wait. So death certificates are super fast also. Funeral directors order online. They can order, and funeral directors can order for up to a year on behalf of the family. They will order it. We do a really big internet business. So, and we also do overnight mail. So we're a really big service provider, and we're proud of it.
That's wonderful, thank you.
Dr. Richardson.
I don't know, too many of you have your mics on. Okay, thank you. Thank you. As always, it's a pleasure to hear from you about these very interesting issues. I guess I just want a little bit more elaboration on one thing you mentioned during your presentation. I completely understand sort of the muddiness of step relations, but I'm not sure why the issues that are raised there would be true of adopted children who would have paperwork to prove, and I'm wondering about not including adopted children in the group that has access. Did I understand correctly that they are not included?
Well, perhaps I didn't explain properly. A child who has been adopted, legally adopted, that's the child of the parent? Absolutely.
Oh, because I thought adopted children were on the list of people who were not included, so I was a little confused by that.
Only if it's adopted and not available, not the original record, not the sealed record.
So an adopted child is no longer the child of the birth parent and not eligible to get those records?
That's correct.
So interesting.
It's sealed. All right, are there any further questions or comments? If not, I would like to thank Dr. Schwartz for the presentation and ask for a motion to adopt the Notice of Adoption, Article 207, Vital Statistics Provisions of the New York City Health Code. They have a motion and a second. Everyone in favor, please say yes.
Aye.
The motion passes unanimously. Thank you, Dr. Schwartz. Are you staying with us for the proposed resolution to amend section 207.05 of Article 7, 207? Are we have you here, or are you doing item number 5 on our agenda as well?
I am.
Okay. Thank you. Let's carry on then. So, just looking up to birth parents.
We are proposing to change the process for transgender birth certificates. a bit of a recap of what we do, what the process is. A transgender birth certificate is we create a new record, and the original record is placed under seal. It is treated in the same way as other sealed record amendments, such as adoptions and paternities. So, really important to just understand that it's not what we call a correction. It's not a correction, it is a new record is created. So a bit of history. This goes back to 1971, when the Board of Health first permitted transgender birth certificates. At that time, in 1971, there were really strict requirements. Amending a record required proof of convertive surgery, which was construed at the time as genital surgery, and a name change was also required. On average, we only had about 20 approvals a year. In 2014, the Board of Health approved a relaxation of that requirement. In 2014, we implemented a process for having an attestation from a medical provider or other professional U.S. licensed to provide the birth certificates. So there were other changes. We went from, with the new process, we went from 20 approved applications a year to over 300 a year. So it was a huge change. We made it much easier for the applicant to get the record. Before, when we had the requirement of having a name change, it became nonsensical. Sometimes we had an applicant whose name was androgynous, say Chris, and we said, we can't process this because you haven't had a name change. So what we could do was say, well, would you like to change your middle name or just change the spelling? So it became nonsensical. So we're very responsive to this. And so we've learned a lot. We've had, through this process of having removing the requirement for surgery and removing the requirement for name change, we have gotten a lot more applications and approvals. So what we've done is we've learned how this process worked. We've done it for about three or more years. And the issue here is that how well were the attesters attesting when patients presented themselves to a clinician or to a healthcare provider. And we felt that did not work that well. And it was mostly because what did the provider actually, what added value was given or provided from the provider? What did they do to add value? So having a practitioner affirm or attest to a person's gender identity, we felt did not add sufficient value, and it added costs and barriers. So there are access to care barriers, there's access to professionals, there are costs. So, and we felt that practitioners were basically acquiescing to a patient's request. Also, the landscape has changed over these last few years. we've received new kinds of requests, like intersex and others, like X, and other jurisdictions have implemented self-attestation and X without concern. The City Council created a Transgender Advisory Board, 7 members, appointed by the Health Commissioner and the Speaker of the Council to advise the department. It met 8 times and had 1 public hearing. The department concurred with the board's recommendation to accept an applicant's notarized attestation. That is, no other proof except the notarized attestation from the applicant. How would self-attestation work? Person 18 years of age or older, born in New York City. That's an important point that I didn't mention before. We can only help people who are born in New York City. So we may have a lot of transgender people living in New York City, but if they weren't born here, they would have to go back to their state of birth to have their record changed and would be subject to the laws of that state, not ours. So 18 years or older, a notarized statement requesting a change on their birth certificate to female, male, and we're proposing X also to conform to their gender identity. Person 18 years, under 18 years, requires both parents or legal guardians' consent. And we are proposing a new category we're calling X. X signifies a sex that is not exclusively female or male. For those applicants who want a designation other than female or male on their birth certificate, these would only be for sex change requests. So it's important to understand that we will continue to follow the U.S. Standard Certificate of Live Birth. So there are 4 choices on the hospital birth record. They are male, female, unknown, and undetermined. So for public health purposes, we will be collecting that same information. So what we're proposing is that after the fact of birth, after that birth is reported, we're proposing that there may be a change. It could be very quickly, but it would require a change, and we would still have our public health information. So 3 states have already adopted X. California, Oregon, Washington State. And federal and state agencies may present some challenges. We've thought about that. And how might that be handled if a federal agency or if a Department of Motor Vehicles said, we don't do X. We only do male and female. So one possibility through self-attestation is that applicant confronted with that challenge could change the record again. Probably not the best thing, but I think that will help push the envelope as well to help our transgender constituents have records that they need for their purposes and for their needs. So with that, I will answer questions.
Thank you. The presentation is now open for questions from the board. Dr. Klitzman.
Thank you again. Your last point speaks to my question, which is whether you're aware of or whether you can envision a person requesting multiple successive changes in their birth certificate to reflect changes in their gender identity. And it sounds like the answer to that is yes, but maybe you can elaborate how that might work.
The answer is yes, and we anticipate that. And in the rest of our business, we have serial name changers. Sometimes they come in once a month. It seems a little excessive, but business is business. For that, we charge $40 for a correction. So yes, so we would accept that, and we feel that there would be important circumstances where someone would have to do that, especially where an agency would not.
Ms. Redletter.
Thank you for this presentation. I think it's very forward-thinking, and I appreciate that perspective. Just wondering, in terms of education of the applicants, the people who would be interested in changing their birth certificates, that we should, it seems, raise awareness about the potential challenges of the federal and state inconsistencies of accepting that category. Just so that's in their general awareness as they, embark on that process.
We agree. When we first changed in 2014, we did a massive education campaign. We had forums, we had chat groups, so we really tried to push that, and we would welcome that as well.
I think at the time of application is what I'm talking about. Just kind of information in general about.
Information sheet.
Yeah, that goes along with the application. Just so people are very
Absolutely.
aware.
Good idea.
Dr. Richardson.
Yes, I agree. Thank you again. It is, I really appreciate the work that the department has done on this and really the leadership role that New York City has taken for a long time in this area, since 1971. I'm just curious as to how the designation X was selected as the category that would be added, as opposed to intersex or gender non-group or some other nomenclature. I take it X does not stand for anything.
Thank you. Yes. We started with a really, really long list. And we looked at it and we're thinking, we're crafting regulations. And we realized that next week it will be out of date. So X is essentially whatever anyone wants it to mean, but we will only stick with that. We will not do intersex on the certificate. We will not have vanity birth certificates. There will just be that, and we feel that will be durable.
Thank you. Dr. Raju, I think you had a comment, or did you have a follow-up?
Again, I just want to join my fellow board members for the progressiveness. Congratulations. My question is, how do the other states which just kind of preceded us, like California and Oregon and Washington, how are they meeting the challenges by the federal government regarding passport and things? Do you have any idea how they do it?
I did get in touch with the U.S. passport people and talked it through with them, and at this point, they're not taking a position, or at least not a public position. So we're very sensitive to it. We're in a position to, we work with all of the states around the country, so we're very much aware of what's going on. It is an evolving system, and we're at the forefront of it. So we're likely there will be changes, but we think having X is is the appropriate way to go.
I have a question, actually. I think that every parent or every child actually is entitled to a birth certificate at no cost at birth. That's correct?
That is, in New York City.
In New York City, yes. But in all cases, this will be a birth certificate that uses the birth gender categories that you enumerated. Will the replacement birth certificate that can be obtained even at, before the request can be made immediately after birth, will that be one that the parents always have to pay for?
Yes. So,
Okay. Thanks,
yes.
that's all I wanted
Okay.
to know. Thanks very much. Dr. Foreman.
Thank you again for a very interesting presentation. So I had a question about an individual who might possess two different birth certificates because they have made a change, and would they both be valid? And what, for instance, I was born male, as an example. I changed my sex to X later, and I have two birth certificates now. I have my original, and I have that one that says X. And now I need to get a passport. I've never had one before, and I go and apply, and I know it's the passport office, so I give them the one that says male. But I have changed it to X. Does the U.S. Passport Office confirm information with the city, or does it just take that official document and go with it?
There actually is a system that we participate in. It's called electronic verification of vital events, that the passport office, actually we're participating in it through the approval of this Board of Health that allowed us to do this. And they can hit against our system to verify the record electronically.
So just to follow that up then, as an individual who wants to get a passport, at the time I apply for the passport, I want my current birth certificate to reflect something that will be accepted by the Department of State, male or female. And then after I have my passport, I could go back and change it again for the $15 fee.
That's correct.
So, on the electronic verification of vital event system, though, if the original male birth certificate was presented, which has now been sealed, would that show up as not a valid certificate in this electronic system because it was sealed when the new X birth certificate was changed?
I think we're going to learn how that will happen.
Works, okay. But what happens now with sealed, if records are sealed because of adoption or, some of the other sealed records, or when they hit the system, are they verified as valid, or if they're sealed, then, or do they not show up as valid?
Okay, so that's a really good point. We update our systems daily. So when we do this was an amended record, we would amend that record. When that record is amended, it will update not only our records, but the electronic verification of vital events system as well. So they'll hit against the system, they will see that it matches. And in the case of the transgender, and if they have an X, that may be something that the passport office may have to figure out, that maybe they will accept the record except for the difference in the gender. We'll learn.
Okay, we'll learn. Dr. Gowda, question?
Thank you, Commissioner. It's not a question, it's just a comment. I just want to applaud your office and the Department of Health for taking this step forward. I think the process that you embarked on was as equally important as the outcome, to really involve the community, to have an advisory board that is inclusive of the community that's affected by this, weigh in and have a voice in the process, I think is very important. And I see this as another step in the march towards recognizing the diversity that is our city, our great city. So thank you very much for your work.
Thank you.
Thank you, Dr. Gadno, for that summation. And now I'd like to ask for a motion to approve for publication this resolution to amend section 207.05 of Article 207. May I have a motion? And a second?
Second.
Thank you. All in favor, please say yes.
Yes.
Any abstentions or no votes? No, so the motion passes unanimously. This will be posted for public comment and a public hearing. Thank you, Dr. Schwartz. Before you step away, I just want to say a few words because this may be the last Board of Health meeting that you present at. We are happy to tell the board that Steve Schwartz has been nominated, I guess, and I will be the next director of the Division of Vital Statistics for the CDC. So we're very proud to see you sharing your wisdom with the federal agency. We don't know how long they take to approve appointments. So maybe we'll get you back in September, but in case we don't, let me just recount to the board that for 20 years, Steve Schwartz has served as our registrar. New York City is the only municipal jurisdiction in the United States that has its own vital registration, and he has overseen it with practicality on view today, with forward thinking, and with great attention to detail. But for 30 years, he's worked at this department. And that's a very long time, and I very much appreciate that long commitment. Every child, even though you haven't signed them personally, and people may think that you have, who has had a birth certificate from New York City in the last 20 years has Steve's signature on it. He has overseen the modernization of our vital registration, all of the things he mentioned in passing, the kiosks, the databases, the digitization of vital records, all happened under your tenure. And you still made time to be active in the National Association for Public Health Statistics. You introduced me to the fact that we oversee vital registrations as a nation in the Mariana Islands, a place that I had never heard of, and which I had hoped that perhaps you'd have a chance to visit one day. It looks so beautiful. It's somewhere in the South Pacific, everybody. But so maybe your future position will take you to these far-flung places, but we will miss your erudition, your wit, your bow ties, at these meetings, as I'm sure will the entire board. You have said that your work comprises sex, birth, and death, but we know that it comprises much more than that. Thank you very much on behalf of all. Okay. The next item is item number 6, proposed resolution to repeal and reenact Article 175. Welcome back to our Deputy Commissioner, Corinne Schiff, but I think introduce yourself once again. And
Good morning, I'm Corinne Schiff, Deputy Commissioner for Environmental Health, and I'm here with Lily Huang, the Assistant Commissioner for Environmental Science and Engineering, and we're here to present the Notice of Intent to repeal and reenact Article 175 of the Health Code, which addresses radiation control. First, a little background on Article 175. The department the article is really divided into 2 sections. First is on equipment. The department permits about 6,500 facilities that use radiation-producing equipment in diagnostic and therapeutic settings. The second part of the article addresses radioactive materials, and there are about 300 licensees that use the material in medical, academic, and for research purposes. We conduct inspections of these to promote compliance with the health code. First, changes we're proposing to the equipment section, we're proposing changes that would align with the Conference of Radiation Control Program Directors Model Code and also with the FDA requirements for X-ray equipment standards. We're looking to incorporate the best practices for quality assurance, and we have not updated these provisions in a major way since 1994. First, looking at the proposed changes regarding X-ray equipment, we propose to add requirements for the operator control booth to specify requirements for space, structural makeup, and the exposure control location. We would require documentation of more patient-specific detail in the technique chart and the logbook, and are proposing to add qualifications for the radiation safety officer. In the hospital setting, the radiation safety officer would need to meet Nuclear Regulatory Commission standards, and in a non-hospital setting, that person would need to be a medical doctor of the site specialty, so a dentist in a dentist practice, a podiatrist, veterinarian, etc. For handheld dental units, these are currently prohibited under the code, and we're proposing to lift that prohibition because there are models that now incorporate FDA performance standards. So we would set out detailed requirements to use these in New York City, including having a backscatter shield, documentation of training, to adopt and follow the manufacturer protocols, and use protective gear. Some of the additional quality assurance measures we're proposing are in hospitals, that there be an annual review of the quality assurance program, and specific to the neonatal ICU, that there be training and measurement protocols. For computed radiography and primary diagnostic monitors, we would require quality control tests to maintain optimum diagnostic information. Proposed changes specific to computed tomography. The facilities would need to be accredited. We are proposing certain quality assurance requirements that there be a radiation protocol committee to establish and review patient protocols, that the facility annually verify patient dose reduction software to be sure it's operating as intended, that twice a year there be quality control tests conducted regarding mandated image quality parameters, that they conduct specific quality control tests for PET-CT and SPECT exams, and for brain perfusion patients that there be an annual assessment of the radiation dose and protocols reviewed for dose reduction. Patient records would have to include the dose recorded by the unit, and medical event errors would need to be reported to the department. For fluoroscopy units, we would require training for operators conducting patient exams and fluoroscopy-guided clinical exams in cardiac catheter labs. There would be an annual review of protocols conducted by a hospital-established committee with the goal of minimizing patient dose and optimizing diagnostic information. Turning now to the materials section of the article, first a little background. The Nuclear Regulatory Commission regulates radioactive materials and delegates regulatory authority over non-reactor sites to agreement states. The NRC monitors state performance and requires that the state regulations be compatible. New York is an agreement state, and New York delegates to New York City. So that means that the health code must remain in alignment with federal regulations. The challenge is that those federal regulations change routinely, which means that we need to be routinely updating the health code. So we are proposing a different approach, which we call site by reference. And this means that we would incorporate the federal regulations by reference rather than duplicate the text. So that would mean that every time the federal regulations are amended, the health code would automatically be amended. This would keep us current without adding any burden to the regulated community. We would maintain the areas where the health code includes additional stricter or more protective requirements. And we wanted the board to know that the NRC and New York State have reviewed and approved this approach. And we can take questions.
Thank you. Any questions or comments? Dr. Richardson?
The breadth of issues brought before the board never ceases to amaze me. I just want to go back to the requirement regarding for brain radiation, yes. So annually assess the radiation dose. Is this of each patient or the dose given by the machine? Exactly what is being monitored?
Yes, it's correct. Requires, requires to
You
document
have to
the notes
introduce
for each
yourself.
patient. Oh, I'm sorry, I'm Lily Wang, Assistant Commissioner for Environmental Engineering, Science and Engineering. Yes, it's correct. Each hospital of technicians required to document the dose to each patient and also showing on their medical records.
Yeah. So I'm trying to understand how to operationalize to annually assess the radiation dose of a patient if presumably my hospital's operators may only have access to their medical records at our facility, and they may have had doses of radiation, diagnostic testing, and so on at other facilities. Exactly what is the responsibility to assess this annual dose?
Sorry, so each hospital, each facility permitted by the Department of Health, they are required to have a radiological protection program. Within that program, there's a QA/QC procedures that encompass two different equipment they use. So they have a documented exact procedures and they have to keep the records of that. So when Department of Health go visit to conduct inspections, they are required to review these records. I don't know if I answered.
Okay, so I'm only
The
responsible.
cumulative dose that she's
Yeah.
asking about
Keeping the-
by the patient.
But I'm only responsible for annually assessing the dose that patient got at my facility.
Right.
I'm not responsible for inquiring or querying whether they received additional doses in other facilities
Correct.
during that year.
Correct.
So it's just at my facility.
Right.
And that's clear in the text of the regulation.
The purpose of that is to ensure, Department of Health is trying to ensure that the licensees had properly managed, not overdosing the patients.
Oh, absolutely.
That's
I mean, I understand the purpose, and this is an issue with a lot of concern. It doesn't really address the larger issue that patients receive care at multiple facilities.
Multiple facilities.
And it's often hard for one facility to know what happened at another facility, and I want to make
Right.
sure we're not imposing an obligation
Right.
to know something that, at least at this point in time, is often not known.
So it is a terminology they often use called ALALA. It's as low as reasonable achievable dose. So that's all we're trying.
First, Dr. Raju, then Dr. Foreman. Were there any questions?
Thank you very much. I think Dr. Richardson makes a very good point. The issue will be for the cumulative dosage, which is so important because we understand better and better that the radiation effect stays with you and eventually it does lead to cancer, which has been very well proven. So we need to calculate. It doesn't just go away after even a year. It takes, it's kind of a part of it remains in the body. So for the residents and for the physicians who really use a fluoroscopy regularly, radiologist and the cardiologist, we all have a meter which basically, measures the total cumulative effect, and then every year we just turn it over, making sure that we are protected. But we need to do something similar to the patients because what Dr. Richardson talks about shows how healthcare is so fragmented because they are all in different places and they're able to deal with it. So that's one point. The second point is most of the radiation overdose occurs in fluoroscopy examination done in the operating room under anesthesia. So because that's the time the patients are asleep and then the people are trying to put in the stents or whatever they're trying to do, and the unconscious patient, usually the dosage has got to be prevented. So a lot of fluoroscopy mission has got what we call timeout. In other words, if you keep pressing on the pedal for more than certain minutes, it just shuts off automatically, then you have to restart it again. Is that a part of the requirement also in your new requirement, that every fluoroscopy machine you use anywhere should have a timeout mechanism so that somebody doesn't just step on it and then forget about it? So.
No. I'm sorry, no. It's only, essentially, there's if it's overdosed, it's required to report to Department of Health. It's within 24 hours.
We can take these as comments and consider them as we take all of the comments from the community and come back to the board in September.
Thank you. Dr. Foreman was next, and then Ms. Redlander, and then Dr. Klitzman.
Thank you very much. I am always amazed also at the breadth of topics that we covered. As a comment going forward then, I'm interested in the ability of patients to access this information. You're correct. Many people mentioned how fragmented care is, and people are receiving both diagnostic and therapeutic radiation at a variety of institutions sometimes. But there's also more sharing of that information, and a smaller number of electronic health record providers are in the community, and we do much more sharing between them. So I could imagine as a patient the ability to see my annual dose this year and last year, and my ability to go through a mechanism within the record to get from other institutions that I've been at and put that together. It's a little cumbersome, but I wondered if you had considered a mandate for transparency for the patients so that because there's much more community awareness of the long-term risks of even diagnostic radiation.
It's in the patient records. In this code, some of the machines required to record that dose in the patient record.
I'm referring to the annual cumulative dose on a patient basis. That, I believe, is not.
So we have not in this proposal incorporated these ideas. I think they're challenging and important. Some of the steps we'd be taking here to require documentation in patient records would be a step along the way to empowering patients to have that information about their own medical history. And it's something we're thinking about, but we don't have a solution to bring to you yet.
Thank you.
Ms. Redlander, Dr. Klitzman, and then Ms. Nick.
Thank you.
Ms. Redlander.
I'm very interested to just see the information that you're presenting here. It seems that a lot of this should already have been in place, requiring training and, certain regulations. Are we saying that there are no requirements like this in place now, or there are other bodies that are responsible or have implemented the requirements that hospitals currently follow? Or
There are requirements already in place. What this proposal would do would be to add specificity to those and to make some of them specific by the type of unit. So the requirements in place are more general. But yes, there are already requirements for training, for quality assurance, for radiation safety committee, and so on. And our inspections of these are quite thorough. I went on one myself, and it was very interesting. We do inspections both of the equipment and also of the records at the facility.
Thank you. I'm happy to hear that. The second question I have is, if we connect to the reference, site by reference concept, and things are changing, I'm just wondering how to make sure that when the changes happen, that new regulation is communicated appropriately to the hospitals and other facilities that need to make that change.
So we'll be thinking about the implementation and hearing from the regulated community during the comment period, but I agree that will be important to make, because this will be an automatic update, so we'll need to be sure that the department is up to date, and also that the regulated community is up to date, because obviously the goal is for everyone to follow the requirements.
Right, so it seems like when there's a change made, there should be some notification officially to the department, which, then would trickle down to the other facilities.
Yes.
Thank you.
Thank you both, and thank you to the Bureau of Radiological Health for all the ongoing work I know that you already do for decades, keeping us safe. My question is whether you can give us a sense of the current magnitude of both environmental exposures from failing equipment as well as individual overexposures. How frequently do you document an overexposure, or if that's even known or tracked?
I don't have the specificity for the exact number, but I asked the question. I'm starting my new job, and we haven't had any reported overdose, notification from the healthcare facilities. We do have some material side, managing it, and we keep a track and we investigate, but not overdose for radiation.
Ms. Naywith and then Dr. Richards.
I'll have to project. Following from Dr. Klitzman's.
No, try again.
Oh, there we
I
go.
turned mine on.
Thank you. Following from Dr. Klitzman's question, is there public reporting on overdose or overexposure? And if there's not, would it be something that as part of this regulation would be proposed?
Under this regulation, anyone can report. The workers at the hospital can report, and the patient can report overdose.
Just to be clear, I need public reporting of the way that public reporting of how the institutions are doing as it relates to the equipment and the use of radiation on patients.
This proposal does not address sort of a transparency component, but it's something we can consider as a comment.
Thank you.
Dr. Raju, was there another? Oh, I can't remember who was first. You debate.
Yeah, so I have a question about this site by reference mechanism, which does seem to be very, efficient and convenient, and maybe this is more of a question for department counsel, but is there sufficient language that a change in the federal regulations in an area where the city had a higher standard or a more specific requirement, is it clear that the federal change would not preempt, if that's the term, the greater standard? Or can we foresee a situation where the federal regulations might actually infringe on something that we specifically do not want to incorporate by reference? And is there language to make sure that doesn't happen?
Well, if the feds were going to do that, I don't think we could stop that. So the preemption begins there, but the preemption here is a floor. So we have, if they make a change, we have to be consistent with that. And you may remember, we haven't come here before you in a while, but we used to come with these changes that were just, so we're trying to avoid that. But I don't believe, like I said, the federal government could decide that they want to take over and knock us out, but they haven't done that. And as it currently stands, it is a floor. We are allowed to be more protective.
Right.
But if they're going to change something, we're going to have to.
Now, I just want to make sure that the site by reference change doesn't introduce a loophole because there's a more recent change, so that there's sufficient language that protects our higher local standard to the extent that we're allowed to have that's part of the regulatory language.
So in the sections where the health code is more protective than the federal requirements, we do not, the site by reference provisions are not included there, and so that would let that stand alone. I think we would have to do an evaluation with each NRC change to see if that does mean we have to make a change to those provisions. There are certain compatibility requirements, but we, and the board has carved out areas where we are being more protective in New York City.
I see, so it's section by section, the site by reference, it's not ubiquitous throughout.
And this is also evident that we have a last chapter of the material section has a QAQC criteria assurance program, which NYC doesn't have and New York City does.
Just so that I'm clear, this is not a provision that the site by reference, that we automatically adopt whatever the federal government has set as a standard, irregardless of the New York City standard.
it would automatically adopt it, but I think we would be taking a look at it so that if there were areas where there was a conflict, we would then be able to address those. But as Lily mentioned, there's an entire section, which is where the health code is really more protective, and we don't have references there to the federal requirements. So unless the NRC really changes its approach, that would be addressed in the way we've structured the code.
All right, thank you, Dr. Raju.
You know, as somebody who ran a hospitals before, there is enormous protection already available. Every hospital has got a radiation safety officer, and they're all Article 28. They're all controlled very tightly by the Department of Health, which basically kind of gives that. And also Joint Commission, which acts as a surrogate for the CMS. If you want to get a Medicaid, Medicare dollars, then you have to really comply with all those kind of regulations, which are being tested all the time as a part of it. So I think it is very well, the safety part of it is very well taken care of. This enormous regulation, safety is a part of it. But what we need to be careful about is not necessarily the Article 28 or the urgent care centers and other things which has got all of them who bill Medicaid or Medicare, they're all perfectly okay. But there are individual small practices in which a physician owns an X-ray machine which is like 30 years old. He just kind of takes an X-ray with that. That would be the area which is not controllable, because that is not the way we do that. And it also happens sometimes in dentists, right, as a part of it. But those are some of the areas which are not necessarily under Article 28. They're not really controlled by many agencies, and that's where I think probably we as a city need to step up and control that.
That point is well taken, and it's a general point that more and more complex procedures, ones not only including radiation, but medication administration are taking place in outpatient settings. And so the need for extension of regulation to that setting is one that we're well aware of. I just want to remind the board that this is you're being requested to approve this for publication, then it will be open to public comment. We often treat the comments that we get from you because you are the ones who approve it for publication, as public comments and incorporate those comments in our response. Are there further comments then, or questions then? May I ask then for a motion to approve for publication a proposal to repeal and reenact Article 175 and a second. All in favor, please say yes. Any abstentions or no votes? It passes unanimously. Thank you very much to the team. We have one more item on our agenda, which is a proposed resolution to amend Article 11. I'm aware that the board received this information on short notice, and I'm glad that we can review it today. You can introduce yourselves.
So I'm Dr. Myla Harrison, Assistant Commissioner of the Bureau of Mental Health, and I'm going to introduce Dan Anderson, who will be presenting.
Hi, I'm Dan Anderson. I'm the director of the NYC STAR program here at the Department of Health and Mental Hygiene. So we are coming here today because the New York City Department of Health and Mental Hygiene is proposing that the Board of Health amend Article 11, Section 1104 of the Health Code related to first episode psychosis hospital reporting. As a summary, we'd like to lower the age of required reporting for a first episode of psychosis hospital admission. We'd like to ensure that we have the complete demographic information at the time that the report is received, and we would like to remove the time limit currently that the department can hold information on those reported with a first episode of psychosis. So a little bit of relatively recent history. In December of 2013, the Board of Health amended Article 11 of the Health Code to require hospitals to report to the Department of Health and Mental Hygiene individuals between the ages of 18 and 30 admitted to a hospital with a first episode of psychotic illness. At that time, the amendment was to address inadequate linkages to care for people with first episode psychosis who often do not seek or become disengaged from care due to system fragmentation, barriers, and exchange of information, providers lacking resources to ensure that the linkages to care are successful, and challenges at the individual level, such as stigma, denial, fear, lack of support, and confusion related to the many resources that we're fortunate enough to have here in the city. In 2014, the Department of Health and Mental Hygiene created and launched a program in order to respond to those reports and offer services to improve linkage to care, and we call that program the NYC START model, which stands for Supportive Transition and Recovery Team. The program provides patient-centered care coordination, psychoeducation, and support services to young adults who have been hospitalized for the first time due to psychosis, and to their involved family members to ensure linkage to care, connect clients to specialized and recovery-oriented services, and support their transition back to the community. By 2015, we had expanded that program to work with all New York City hospitals with inpatient psychiatry and offer services to any New York City resident who meets the reporting criteria. So how that works out is that hospitals alert the Department of Health and Mental Hygiene when an individual is admitted with a first episode of psychosis. A team here, the NYC STAR team, responds to those reports, makes contact with the hospital, and when it's clinically appropriate, which is something that the hospital tells us, we respond to the hospital to meet with the individual and provide them with information about our program and services. The program is a voluntary program, and so if the individual agrees that the Department of Health and Mental Hygiene team engages him and or his family to link the treatment and follow up to ensure continuous care. Services are provided by a team made up of a social worker and a peer specialist. They're provided in the community and for approximately 3 months following hospital discharge. So far, the program has been successful. We have improved successful linkage to outpatient care, and we are well received by program recipients and providers. As of May 2018, the NYC START has responded to over 1,700 hospital reports. 1,127 people, or 73% of those eligible, accepted NYC START services. Since the program launch, overall, if we look at it as one large number, 80% of program participants have successfully attended an outpatient mental health appointment within 30 days of hospital discharge. And that's a number that during the life of this program we've been working to improve on. So in the first quarter of 2018, it's over 87% of participants have attended an outpatient mental health appointment within 30 days of hospital discharge. In doing this program for the last couple of years, we have identified some unanticipated barriers to care, and that's why we're here today, is to try to address those. So we know that it's critical to individual outcomes to connect people with first episode psychosis to services within the first 5 years of the illness's onset. However, due to the current restrictions in the health code, we're unable to do that as completely as we would like. So the health code amendment currently applies to individuals who are 18 to 30 years old and doesn't allow us to address the needs of 16 and 17-year-olds who are admitted with first episode psychosis. At the time that the proposal was put into place, we did not include racial or ethnicity information as part of the required report. And because of that, we are unable to assess for racial inequity among first episode psychosis referrals from inpatient psychiatric care. When we put the proposal in place, we had a 30-day time limit that we would keep identifying information reported to us. But we'd like to extend the length of engagement beyond the first 30 days because often we're finding that people aren't necessarily able to make a decision about accepting our services within that 30-day time frame, and there are a number of cases who are otherwise eligible that we have had to close our outreach efforts to because of the time limitation. We would also like to be able to evaluate the effectiveness of services for those who participate and those who do not participate in NYC START to determine whether or not there are additional needs in the community that should be addressed through alternative interventions. So to take each of the 3 proposals that we'd like to modify, what would be the impact of lowering the reporting age to 16? So we have done a recent analysis of New York City hospital admissions for first episode psychosis between 2009 and 2016, and we found that between 4 to 6% of those admissions were among 16 and 17-year-olds. When we initially put this proposal forward, some questions had actually been asked of us. How come 18? Why not younger than 18? And at that time, we pointed out that the purpose of the report was to be able to provide a service. And there were simply not sufficient services available to people under 18 for us to connect them to that were specializing in first episode psychosis. But since 2014, there has been an expansion in specialized first episode treatment programs in New York City. Those specialized programs provide services to individuals who are between 16 and 30 years of age. And we would like to align our reporting and our ability to connect to care with those specialized providers. And at the time, as I mentioned, the Board of Health, at that time, there were some members who had mentioned that it would be desirable for us to age down. And so we're really kind of happy to be able to come back here and propose to do so. So the impact of collecting race and ethnicity. Currently, race and ethnicity are not reported to us at the time of report. Adding race and ethnicity information would allow us at the department to assess for racial inequity among referrals within inpatient psychiatric admissions, better identify whether program changes or alternative interventions are needed to address disparities in access to services for individuals with first episode psychosis. And as we've reached out to stakeholders to speak about this proposed change, it's been a positive response. Actually, the response has normally been, really, you don't collect that already? And the impact of retaining reported information. So, requiring hospitals to report cases of first episode of psychosis has resulted in over 1,100 people to date receiving services to connect to care through NYCHealth. However, we've been unable to provide those services to more than 400 eligible individuals due to our inability to continue follow-up after day 30. That's about 25% of the eligible people who have been reported to us. So it's maybe 400 people doesn't sound like a large number, but we like to think it's actually a pretty large proportion of people who could, we think, benefit from our services that we have been unable to provide services to. By retaining identifiable information, we'll be able to extend engagement efforts beyond the 30-day period. We hope that would promote the health of individuals with first episode psychosis, allow us to better assess trends and outcomes based on successful engagement, and work with providers to develop successful interventions. I'd like to point out that unlike all other reportable conditions, information reported to the Department of Health and Mental Hygiene on first episode psychosis is uniquely de-identified after 30 days. And that the Department of Health and Mental Hygiene does manage numerous disease registries and has extensive experience maintaining the confidentiality of identifying information and protected health information reporting to it. So our proposal to amend Section 1104 is that a hospital must report to the Department of Health and Mental Hygiene the admission of any person 16 years or older with reportable psychosis diagnosis. That reporting will continue to be required within 24 hours of admission and will include hospital name, patient name, age, gender, address, telephone number, date of admission, insurance type, what would add race and ethnicity, and of course it includes currently diagnosis. That all reports would remain confidential, and that identified information reported to the department would not be subject to inspection by persons other than authorized personnel of the Division of Mental Hygiene, and may not be disclosed without the consent of the person who is the subject of the report or someone authorized to act on such person's behalf, except pursuant to federal or state law that would compel such disclosure. That's our proposal. I'd be happy to answer questions.
Thank you very much. The presentation is now open to questions and comments from the board. Why don't we just go around this way then? Looks like there are a lot of comments. Let's go.
Hi, good morning, and thank you so much for addressing this issue for this number of young individuals in the community. I'm just curious about why age 16. I think my recollection from the literature is that the onset of psychosis episode is around age 14. So I'm just wondering whether is that New York City is different in a way that we have more episodes between ages 16 and 17. And then the other question that I have is, given the experience that you have already running this program, to what degree are families involved in this process? This, in a way, they're minors. So is the family, in addition to the reporting from the hospitals, to what degree are you involving families in this process?
So thank you for that question. As to why 16, I mean, there's no magic cutoff number for when somebody could have an onset of psychotic illness, but we are really interested in aligning ourselves with the specialized service providers that are available in New York City. And in New York City, they are age 16 to enroll in services. That's actually fairly consistent in most of the early episode psychosis treatment providers, both in this country and internationally. I guess 16 to 30 has sort of been the time frame that people have landed on, has not only been the vast majority of people who manifest with a psychotic condition, but when the specialized services that can be put in place would be most impactful. So family involvement. Yes, we currently do have a lot of family involvement. Currently we're working, of course, with individuals who are 18 to 30, and some of those individuals may not allow us to involve family. We know that we are much more successful, however, when we can involve family members, and so we go to great extent in that 3 months that we're working with people, if they're not initially receptive to us working with family, to build the trust where they will allow us to work with family, because we know the family will be there after we go away at the end of 3 months, and the more we can do to support the family, the better the outcome is going to be overall. Obviously, aging down to 16, there will be a much greater emphasis on making sure that we've got family involvement and agreement at the very beginning.
Thank you.
You know, I think it's a very progressive way of doing that. I really want to applaud you for doing that. But the two issues which you need to be careful about, because having worked on collecting these demographic or the race and ethnicity data, we encountered a couple of problems. The first problem is the person who really collects information is a clerk, right? And they're not very, they feel very, not very comfortable asking somebody's race and ethnicity in a much more way. That's one thing. The second thing is also race and ethnicity is identified by individuals, because more and more interracial marriages come in. It basically, the person says, I want to identify myself as a particular race, right? Because people are uncomfortable asking a friend, and the fact of the matter that people got to identify the race, depending on, you know, what, if they're interracial couple, and they want, if you're a son or a daughter of interracial or ex of interracial, then you have an opportunity to identify yourself at what your ethnicity should be. Because of this problem, we encountered a huge problem, but people start profiling, don't ask the question, they just profile them and say, okay, this is a race, or they look at the name, the last name, and they say this is a race. So that has become a huge problem in the country of collecting the right information. So I don't know what the solution will be, I can't give you that, but I just want you to make sure that as you collect these things, these are really what people want themselves to be identified as, not by just profiling, looking at a person, phenotypically how they look like, or look at the name, the last name, and say, okay, fine, this would be the ethnicity of the person.
I take that as a global comment and an issue for all of public health, so I appreciate that.
Just a clarification. Did I understand well that is the time after the 30 days is unlimited? Obviously related to New York City STAR program. Is unlimited for the
The proposed change?
Yes.
Okay. Yes, the proposed change. Right now, information that's reported to us is de-identified on day 31 after the report is made. And our proposal is that we would cease de-identifying information on day 31 so that we could be a little bit more effective in our ability to conduct a longer outreach. But also, an observation that I'll make, having done the program now for a bit, is that as we do the program for longer, there is a greater likelihood of people calling from different hospitals, and not every hospital knows that somebody was admitted to another hospital, and asking us, should I report this person to you, or have they already been reported by another facility? And right now we have no mechanism to be able to say, oh, we've already received this report, or we have not.
Thank you very much for the presentation. As I believe one of the board members who asked about moving the age lower the last time this was presented, I can't believe it's as long ago as you said. I'm really very pleased to see that that's happening. It is a small proportion, but I was very impressed in that initial presentation some years ago, and did some reading afterwards about the critical importance of early engagement and treatment for first grade psychosis. So this is really great. And I thank you for that. I had two specific questions. One is in the following up on the race ethnicity designation, many forms offer the option to decline to respond. And I wondered if you intend to include that. And then the other specific question is about confidentiality. So you point out that these records are treated differently than all other information reported to the Department of Health, but actually throughout our documentation of medical information, we do treat mental health records differently in many cases with an added layer of privacy. So I wanted to ask you a little bit about what do you think about that broader rationale for additional protections for mental health records, and whether there's anything else that should be considered here between 30 days and all information is removed and no limit and all information is retained.
Thank you. I think that the way we would address reporting from the hospital about race and ethnicity is we would have the ability for somebody to check unknown, unanswered, as well as on our end on receiving it unreported. Because we do know that the information we get is only as accurate as the person who's making the report at the time. And that may not be something that they are able to report to us. I am anticipating that we may receive other comments during the comment section, and that we will have probably some categories that those comments fall into about the keeping the information for longer. I think that probably the underlying concern about most of those comments is going to be about our ability to adequately protect the privacy of this information reported to us. I think the underlying theme is going to be concern about privacy issues. And to that extent, we would hold this information to the highest standard that we could here at the Department of Health and Mental Hygiene. I personally look towards the mental hygiene laws set by the state, which is a higher standard of protection around that. And I would want our ability to protect the information reported to us to be consistent with that higher standard, because we do want to keep this information protected, we want to keep this information private, we want to ensure that there is a sense of confidence in the department's ability to manage this, but I think that we can. I know that we have other protected health information reported to us that is also equally sensitive and very private, and those bodies that collect that information have a good track record of making sure that it's adequately managed.
Thank you.
Okay, so I'll try to be brief. Again, thank you for coming back with the expansion of age. I too remember when this initial change was made. For myself, I'd like to express my confidence in the department's ability to maintain the confidentiality of protected health information that's reported to it. As you mentioned, I think the department has a strong track record on this with many types of sensitive health information. I think the benefits of being able to continue to offer outreach and the possibility of services to these individuals outweighs what I regard as a very minimal risk if the department maintains the record. So I support that change also. I do want to make one comment on the race ethnicity data. I appreciate the issue that was raised by Dr. Raju. It is unfortunate that many hospitals have not adopted evidence-based approaches to collecting accurate self-reported data. There's good evidence that when staff are trained, they do ask it and people do not object, but there's sort of this myth that, don't ask, don't tell is the order of the day, and that really is not the case if you look at the literature. And so I support adding that. You only obviously can get what the hospitals have collected, and that is a huge public health issue that all of us need to start to continue to work on in both sectors. I do want to raise the issue, though, of limited English proficiency and preferred language. This, of course, is an important barrier to access in all dimensions of health, but particularly in behavioral and mental health services. And I wonder if you wouldn't consider getting information, if it is available, on the patient's preferred language, as that would be really central to making referrals and to appropriate linkages to care. So I would ask that you consider adding that to the demographics that reported. Again, if it is available in the hospital records or to whoever is doing the reporting. So I'd just like to make that suggestion.
Thank you. I have a couple of questions. Dr. Gill raised the question about family involvement. Will participation of 16 and 17-year-olds require parental consent?
That is actually something that is currently being discussed. I would say 99% of the time it would in the normal course of operations. One of the things that we're looking at right now is what do we do and how do we extend an offer of services to somebody for whom there is not an involved family member who can consent, or for whom there is a risk of harm that has allowed the 16 or 17-year-old to prevent a family member from being aware of their seeking services. And we are actually working to be able to address that when it comes up. But for the vast majority of cases, our intention is that the offer of our services would take place within the context of a family meeting.
I think from a practical standpoint, that's amazing and wonderful and to be applauded. I have some questions about the independence of the adolescent to make their own choices and to self-refer in the same way that we handle reproductive health issues. So I would just say it's worth really looking at. That's number one. Number two, what is the time frame that most of the other disease registries use? If there's supposed to be a first report that comes in, is it indefinite? I think that was a question that was asked a little bit before and not completely answered.
So my understanding, all of the other registries keep the information indefinitely.
Okay. And even though this is a program targeted to first break, it would be open indefinitely. You wouldn't see a little bit of a tension there. Theoretically, someone who has a chronic serious medical condition perhaps may have another episode. How would you handle that? If it's designed only for first psychotic episode.
So if I'm understanding the question correctly, it's saying that if what we're interested in here is the first episode of psychosis, how would we manage if that then continued to be further episodes of psychosis?
No, that if the intervention is designed to address a first break, assuming that people with chronic conditions may have other episodes of psychotic episodes. So what do you do? I mean, would it be open indefinitely? 30 days is too short, but indefinitely may be too long, I guess is what I'm trying to say. If the intervention is targeted to people with first breaks, so there may need to be some other kind of a cutoff parameter.
Yeah, both Dr. Foreman and Dr. Richardson remind me that there's several members of the board who weren't present when this was initially proposed to the board. And the underlying rationale for it is the greatly improved prognosis of treatment, which is introduced early following the first episode. That's why the board took the novel decision of making this a reportable condition. And it applies really to the first episode, and that's what this is limited to. The issue is that the ability to link to care may not be possible within the window of the previously agreed to time frame. And we want to maximize our ability to ensure the benefit of entrance into care after first episode psychosis. The problem of chronic psychosis and its medical care is really not addressed by this rule. Of course, it's a large issue. People coming in and out of care is something that happens very frequently, but it's not addressed by the rule regarding first episode psychosis. If you excuse me do you want to add to that?
I think you answered it very well, thank you. The only thing I would think to add to it, though, is that the first episode is a critical time for intervention, but it opens a window of intervention opportunity, and international consensus is that the first 5 years of onset is a critical time for intervention, and so we would want to be able to look at much longer than that 30-day period, because we know the first 5 years is really the critical window.
That was the parameter I was looking for. And then thank you. And my last question has to do with the geography of treatment available. And so you are tying the expansion of 16 and 17-year-olds to the availability of services. And so one of the big disparities in our city is, in addition to race and ethnicity, is also geographic access. So it probably would be useful to know where the programs are located and how they work with these young people and their families as part of the follow-up conversation. Thank you.
Yeah, and the specialty care providers that have expanded across New York State and across New York City since we first came to the board and had this proposal added to the health code have grown dramatically. So there are now specialized first episode psychosis providers available in every borough in New York City. There's 12 specialized teams that operate, and they are dispersed across the entirety of New York City.
Hi, thank you. There have been so many good questions. I really just have a very specific suggestion or a question about the race and ethnicity accuracy. I'm just wondering if there's an attempt, or can there be an attempt to review the race and ethnicity with the patient or family after it's initially reported and modified? Or is that something that's just the initial report stands and we can't change that?
So when we work with people now who accept services, we do ask them how they identify their race and their ethnicity. We would do the same. The added value of having it part of the report that's made to us is we don't actually always meet everybody who's reported to us. There are some who are reported to us who we never successfully are able to speak with, or sometimes for some of those meetings, they're very short for somebody to tell us how uninterested in our services they might be, and then to follow up and say, but would you care to identify your race and ethnicity for us, probably wouldn't go over well.
Right. No, I understand that. I'm just, in the current modification, we will have it, and there's some concern about whether it's accurate. So if you do engage them, is it possible to update the information?
And we absolutely would, yes.
Thank you both for your cutting edge work on this. I mentioned to your predecessors back in 2013, this is an issue very near and dear to me because my first semester of public health school in 1980 as a work study student, I was a research assistant on a study where I had to go out and interview young people during their first break hospitalization, and I kind of remember what an experience it was to see people in the midst of their psychiatric breakdown, and I would like to think, I hope not being too immodest, that perhaps the information I collected helped to get us where we are today, although so many great strides have been made since then. My question is, could you just summarize for us what is the role of the hospital versus the department in linking people to treatment, and whether that is changing at all with these revisions?
So with these revisions to the proposal, no, there isn't a change. The hospital is, of course, responsible for developing an aftercare plan. What I like to think of as one of the values added to the hospital of our program is that because we are so focused on this specific population, which is, after all, the low incidence population, and is not your everyday admission to a hospital, we are able to bring to the hospital up-to-date resources and information on what the most effective specialized treatment out there might be at that given time and that given moment, and be a bridge to, even for people who do not accept our services at the end of the day, be a bridge to informing the hospital on where the best treatment plan might be. So we don't make the treatment plan, the hospital makes the treatment plan, we then support the treatment plan, but we try to inform it so that it would involve specialized services wherever appropriate.
Thank you.
And Dr. Gowdy.
Dr. Gowdy. Thank you, Commissioner. So I had a question about the services that that these patients would be connected to regarding two issues. One is if the patients have housing insecurity and are homeless, how do you coordinate with shelters so that so the information and treatment services could be effectively coordinated? A second issue is patients that do have their first psychotic break in the setting of substance abuse. Do you have linkages to treatment programs as well as psychiatric services?
So certainly housing insecurity is a really significant issue for us. To that end, our program has taken the step of becoming able to do the housing applications ourselves, because we found that even though it's a 3-month program, within that 3 months, we can actually take somebody from lack of housing to the ability to support them through the process of getting housing. We work with the shelters where there is an opportunity to promote the ability to transfer to a mental health shelter, which will have slightly better resources and services for somebody with a mental health condition. We advocate as best we can for that. But it's truly a challenge for us. And housing insecurity, of course, is going to really shape anybody's ability to follow up with anything else. In terms of substance use, yes, I'm very sorry. In terms of the substance use, so the list of diagnoses that are reportable to us excludes substance-induced psychotic disorders, so we currently don't receive those at all. We do work with people who have co-occurring substance use. That's not an exclusion for us, but somebody has to have a primary psychotic in the schizophrenia spectrum diagnosis for us to be able to work with them. And the reasoning behind that is, once again, to align with all of the evidence-based first episode psychosis specialized services that are available who follow that same guideline.
Dr. Gill. Thank you.
Thank you so much again, and just a follow-up question regarding my colleagues here at the board have raised questions about the accuracy of collecting data about race and ethnicity, and also the issue of geographic location for the providers to address the needs of these young individuals. My question is, do those providers have the capability of bilingual, bicultural mental health providers, particularly if families are participants and they're immigrant families? Many of them may not have not be able to communicate in English. So the capacity of our bilingual, bicultural providers.
And I also wanted to say that that was a great comment and one that I would like to incorporate so when we come back It's actually one of the first questions we ask when we get on the phone is, what is the language that we need to be able to communicate with this person? And it would make so much sense to get that at the time of report instead of at a follow-up phone call. We, personally within our organization, we have to use translation services for languages that are beyond the ability of our staff. We're a small program. We have 9 social workers and 4 care specialists, so we can't possibly be able to have bilingual staff in every language spoken in New York City. And so it's not perfect, but we use the translation services for when we need to communicate with either the client or their family where English is not the first language. For the connection to care that we do, we, of course, take language ability as one of the top stratifiers of what connection to care would be appropriate. The specialized services that are available throughout New York City, it depends on the program and the staff in that program at that given time what the language capacity is. Most of the programs have some provision for some bilingual, culturally informed care. I wouldn't say that all of the programs speak all of the languages, so it really does vary. And if the individual we're working with, that their language needs would be better met at a different program, then we would either work to transition that person to the program that would better meet their needs, or to identify at the very beginning that this will be a language barrier for this particular program, and we suggest this other program will be better equipped.
Thank you to all members of the board. Are there any further questions or comments? If not, let me just make a comment on the questions regarding race, ethnicity, data collection. The data that we collect in general in public health are in fact flawed along the lines that Dr. Raju has noted. Nonetheless, they show big gaps in both exposures to unhealthy conditions, health outcomes, access to services, and at the moment we're unable to assess those gaps in this program. And so I think it'll be a great step forward, and appreciate the additional sources of barriers, including language, that we should be mindful of as well. If we don't monitor it, then we can't measure it. So with that, I'd like to ask for a motion to approve for publication the resolution to amend Article 11 regarding first episode psychosis.
So moved.
And a second? Second. And all in favor, please say yes. Any objections or abstentions? The motion carries unanimously. Thank you very much. That was very helpful. And there being no further business to discuss, I'd like to thank the board members as ever for their eager and thoughtful participation, and declare the meeting adjourned.